Okay, so it's 7 p.m. and yet again we welcome you to this Liver MRI webinar series at Collected Minds. And again, thanks to our sponsor, Bioradiology Nordics, for enabling this educational event. So tonight we will have Dr. Nikolaos Kartalis, who's a senior consultant radiologist at Karolinska University Hospital in Stockholm and an associate professor in radiology at the Karolinska Institute, presenting the topic of malignant tumors, providing an overview in this field. And with us also, we have Dr. Martin Tomeer of Erasmus MC in Rotterdam, whom you know from previous sessions. So Martin, you'll be moderating the questions. And I also want to recommend everyone who didn't yet do it, please go to Collected Minds and access the group page of the Liver MRI webinar series, where you can follow along these cases yourself. We will record this webinar, so it will be made available after this live session tonight, along with the cases and also a possibility to ask questions with respect to the cases. So with that brief introduction, Nikolaos, the stage is yours, and thank you for joining us tonight.
Thank you very much, Fredrik, and thanks to Martin too for moderating the session. It's a great pleasure to be here, and I would like also to thank both Collective Minds, Radiology, and Bayer for the opportunity to be here. So we will. These are my disclosures. My institution has some consultation fees from Bayer for the various lectures, and the learning objectives of this talk will be to understand the basic principles of the evaluation of the most common malignant liver tumors with MRI, and to be aware of potential pitfalls and how to avoid them. And of course, I can't promise you that you will love liver MR after this talk, but I will do my best to reach at least the learning objectives. So in order to do that, I will start with a short introduction, how I look at the cases. We'll go through the basic principles of metastasis and the malignant tumors, metastasis, and the primary ones, the HCC and cholangiocarcinomas, how we see them on imaging. Then we will discuss some interactive cases on the platform of CMRAD, and then I will point out some pitfalls that you need to remember during the talk. And then I will finalize with a take-home message. And hopefully we will have time for some questions, or if you have any burning questions during my both lecture and the case discussion, please post them in with the tool so Martin can address the questions and we can discuss them. So starting from the introduction, this is actually the image of a PACS system, and I would like to go through how I approach this case, just to give you, to share my experience on the topic. So I usually hang the images, I make the hanging with the T2, just to get the information of the fluid content. Then immediately under I have a diffusion to get information about the cellularity. I have also the vascular images, the T1 before and after contrast for information about the vascularity of the lesions or the organs. The hepatobiliary image for the function, if you have a possibility to use Primovist or multi-hands. And then finally, in the post phase for information about fat and serum content, ferrum content. So in all this we do in order to get information, in order to achieve the goals of the imaging, to detect lesions, to characterize them, say if it's hemangioma, metastasis, or HCC, to get information about the prognostication. Let's say a patient with HCC and macrovascular invasion has worse prognosis than a patient with HCC of the same size but without macrovascular invasion, and of course help in treatment planning and response evaluation. So for the basic principles, before we start with the malignant lesions, the secondary and the primary lesions, I would like to go through some of the benign lesions that we often encounter and may pose difficulties in the differential diagnosis. To begin with is the hemangioma. Typically, these lesions have a high signal intensity on T2. It should be almost as high as the cerebrospinal fluid. After the injection of contrast, we see the peripheral, nodular, discontinuous enhancement with centripetal fill-in. And of course, in the hepatobiliary phase, we don't have any uptake since hemangiomas do not contain functioning hepatocytes. But we have to remember that this rule has to be strictly followed. The peripheral, nodular, discontinuous enhancement following the blood pool, regardless of which contrast agent we use. The enhancement pattern has to match the part of the vessels that are on the screen, either if it's veins, arteries, or even the portal branches. Another lesions that we need to remember are the cysts. As we see here, T2 and diffusion on the low B values, we can't really tell which lesion is which. However, when we add the B800, we see that hemangiomas is still has high signal intensity compared to the cyst that disappears. And we have to remember that both cysts and hemangiomas should show no signs of impeded diffusion, so they are bright on the ADC map. So going to the metastasis, the secondary tumor that is the most, it's very common seen in the liver. The combination of diffusion imaging and hepatobiliary phase gives a sensitivity of 95%. These numbers are crazy high. These are like a dream to be able to diagnose metastasis with this high sensitivity. And a typical case scenario, we have a patient with colorectal cancer showing a typical metastasis on the CT, and another hypodensity that we don't really know, and our friends, our colleagues from the surgical department go crazy when we tell them that these lesions are too small to characterize. So they ask us, what is this lesion? So we often go to the MR, and we can see with MR that this small lesion is just a cyst with a high signal intensity of T2, seen on B50, disappearing on B800, and of course, no hepatobiliary function. And in the same image, as you see, we have another metastasis with impeded diffusion, no uptake in the hepatobiliary phase, and slightly hyperintense on T2. Moving to the HCC, these are mostly seen in patients with cirrhosis, of course. In a small percentage, we can see HCCs even in patients without cirrhosis or chronic liver disease. The critical parts for the diagnosis are, of course, the arterial phase hyperenhancement and the washout in the venous or late venous phase, according to the EASL, and of course, similarly to the LIRADS version 2018, where we base a lot of our diagnosis on the non-rim arterial phase hyperenhancement. The additional major features are enhancing capsule, non-peripheral washout, and threshold growth. So the most important part of the HCC diagnostic is the vascularity of the lesions. That's why these are the major findings. I show you here some images of a patient with cirrhosis. We have a lesion enhancing the arterial phase hyperenhancement with venous washout in the portal venous phase. Major findings, ancillary findings, we have impeded diffusion, we have a slightly hypertension T2 and low uptake in the hepatobiliary phase. Another case, patient again with cirrhosis, arterial phase hyperenhancement, washout in the portal venous phase, and the ancillary findings of moderately high intensity on T2 or discrete high intensity on T2, impeded diffusion, no hepatocellular uptake, and again, low signal intensity on 3 minutes phase. I would like to point, as Martin has said in one of the first webinars, that we don't use the term vascular washout in the 3 minutes phase after Primavist, since this is a transitional phase, something in between the vascular phases and the hepatobiliary phase. We have to be very careful and not call this one for vascular washout. This is just hypointensity in the 3 minutes phase or the transitional phase. Moving to the cholangiocarcinoma, these are fiber-rich tumors. They can be seen in both healthy livers or cirrhotic patients. Typically, they have peripheral enhancement that fills in progressively towards the center. The late venous phase, you see almost complete enhancement. And of course, in the hepatobiliary phase, we don't have any uptake since these lesions do not contain functioning hepatocytes. On the T2, we have slightly hyperintense, by no means as high as the cerebrospinal fluid, and of course, restricted diffusion. If we are lucky enough and we have the hepatobiliary phase, And the diffusion weighted image, sometimes we can see the targetoid appearance, as we see here, and in the periphery, on the hepatobiliary phase, hypo-intense periphery with hyper-intense center. In the diffusion, we have hyper-intense periphery, hypo-intense center. Intrahepatic cholangiocarcinoma, targetoid appearance, very helpful sign. So we are moving now to the interactive cases. So I would like you to, if you have the possibility to log in the platform, you can all scroll together with me. Or maybe you have already done this during the day, but anyhow, we start with the first case, a 72-year-old male with colorectal cancer. So of course, we suspect that there is something in the liver that we need to further. He shows an unclear hypodensity in the liver. So we have the Primovist enhanced liver MR. So I start with the viewer. So of course, we have to remember that metastases are something we need to clear for the liver, just in order to improve the staging of the patients. So we need to, let's see if the images are appearing. Yes. So I will explain usually my hangings. Unfortunately, the series don't have the name, the terminology of them, what disappeared during the anonymization process. But I always hang the T2 diffusion, the dynamics, late arterial phase, portal venous phase, 3 minutes phase, and the hepatobiliary phase when it's available. But we need to remember that the diffusion images have to be reviewed together with the ADC map. The enhanced images have to be reviewed together with the unenhanced image, just to see that some enhancement is really enhancement and not pseudo enhancement. And of course, we have to remember that in and the post phase have a certain role in some of the patients. So I have noted some of the lesions here, the one lesion that we had on CT. And I will try to explain the findings, and then you will vote for them. You are free to scroll if you are on your viewer too. Otherwise, we just look at my image. Of course, I do. We start with the diffusion. We see very beautifully the lesion here on the right liver. We see it on T2, intermediary high signal, not as much as the T2 on the CSF. On the enhancement screen, we see maybe some peripheral enhancement. On the portal venous phase, some kind of nodularity in the lateral aspect of the lesion. The 3 minutes phase, again, maybe some nodularity here. And the hepatobiliary phase, no uptake. So take a look, a few seconds, and I would like Fredrik to show the first question, if it is possible. Yes. So what is the most likely diagnosis for this patient? Is this a hemangioma? Is this a metastasis? Or is this intrahepatic cholangiocarcinoma or an HCC? So take a few seconds to think. I will show you, as said, we need to use diffusion images together with the ADC map. So I will show you the ADC map on this image before you vote.
And we'll keep the vote open.
So please consider giving some votes. So this is the lesion on the ADC map, the same lesion we saw on high B diffusion values, T2 with intermediary signal on T2 and some nodular peripheral enhancement probably in the lateral aspect. So please give me some votes.
Okay. Okay, so we'll keep it open for a few more seconds.
Yes, please.
Okay, so I think we are 60% voted, so we'll just end this.
Can we see the results?
There we go.
Okay, excellent. So 70% say hemangioma, 20% go for metastasis, and 7% HCC. Okay, excellent. This is a very nice and illustrative example of how things can go wrong. Because if we go back to diffusion, and I will show you the images here, I would like you to notice something that is quite weird. We are talking about high B diffusion images. Okay, so you see the spleen is like we expect spleen to be, but we don't see any liver actually. You see the stomach, you see the lungs somewhere here. This is the heart, if I remember well from the anatomy. This is the right lung, this is the left lung, but we don't see any liver, and we see a lesion, a liver that doesn't exist on diffusion. So if we go back to the same patient, I will close this viewer and I will open case R1, which is the same patient with another contrast agent, multi-hands, and hopefully we get the correct answer immediately. So this is the same patient 1 week later than the previous exam, because we were a bit unsure if this was a hemangioma or metastasis. We were a bit afraid if the enhancement pattern was not clear enough, as we would expect with hemangioma. And this is again the ADC map. This is the enhancement pattern. We see some nodularity in the periphery, but actually when we follow the case in the later phases, there is probably some peripheral enhancement, but it's for sure not discontinuous. Some nodularity is here definitely, but if you see, there is already the rim enhancement in the whole of the lesion. But the most important is the ADC map. This is something that fooled us too during the conferences, because we see the hyper intense lesion compared to the background. But if we look at the in and the post phase images, I will show you here the in phase and the opposed phase. So this is the opposed phase image. And you see the signal on the out of phase is much higher than the signal on the in phase. So actually the patient had hemochromatosis, which made the findings of the diffusion a bit unclear. So I would like to ask Fredrik to go for the second question. So what are we seeing on diffusion? We see the ADC is bright compared to the adjacent parenchyma. So is this indicative of a hypervascular lesion? Is this indicative of a non-hypercellular lesion? Or is this non-reliable? So let's get some votes. And during the time, I can show you the images again. So this is the opposed phase, and this is the in-phase image. And I will get the ADC map again on this side to indicate where the lesion is. So, do we have some results, Fredrik?
Yes, we have some results. So I will end the poll now. We're just getting the final answers here. Here we go.
Excellent. So this is the tricky case I showed you here. So if I go, so the majority, 60%, say that the findings are not reliable, and 20-20 hypercellular or non-hypercellular lesion. So let me go back to my presentation and discuss the first case. So we need to remember that high B values need to be evaluated with ADC together. So as I showed you here, we had the high intensity, the lesion with high signal intensity would be 800 and bright on ADC. So we think that this is probably a benign lesion such as hemangioma. However, we have to remember that diffusion is a sequence that has a lot of technical challenges, a lot of artifacts from air, artifacts from metal objects, etc. And an artifact that I showed you here is from hemochromatosis, because when the liver is not normal, the background liver is not normal, then we can't really evaluate findings of a lesion being hyper or hypo-intense compared to the adjacent parenchyma. So in cases where we don't see the liver on the diffusion-weighted imaging, we have to rethink, is this a normal liver or something is going wrong, most often with hemochromatosis. So this case was not hemangioma. This case was a metastasis, and we know that because we did a follow-up on 3 months, and the lesion doubled its size, and then the surgeons removed it, and it was shown to be a colorectal cancer metastasis.
And Nikos, I have a question, a small question.
Yes.
So in comparison to the surrounding liver, you cannot say if it's hyper or hypo-intense on the ADC, but you can also measure the absolute value of the ADC. And you will see in this case that it is hyper intense on the ADC, but if you measure, it's maybe below 1. Then it will act like restriction. Would you agree with that?
This is actually a bit challenging because the measurements vary quite a lot between different vendors and even in the same vendor in different systems. So the absolute values have to be taken with a very high consideration and carefully
yes,
because
I agree. Yes.
the values may not give you the real answer. Of
Yes.
course, if you have tested your system and you see you are pretty sure of your measurements, because you need to remember that even in the best of the all worlds, the variation between the ADC values can vary. It can be up to 20 to 30% even in the same patient in the same machine in different time points. So absolute values can be tricky, but the idea with this case is to show that the surrounding liver has to be evaluated together with the lesion. So yes, the lesion itself is difficult to evaluate if you don't have the surrounding parenchyma.
And another interesting question would be, yes, if there's a problem when you have hemochromatosis, would you also have a problem if you have steatosis?
Actually, this is the less difficult problem because the liver does not disappear during the
but it will change. It will change in comparison to the lesion, no?
It will change a bit, but not much. It will not disappear. It will not disappear. So liver steatosis is a problem when we evaluate the MR images, but still we have in and the post phase, so we can at least get that there is something wrong in the liver, but still the ADC is reliable at least when the liver is still not completely fat replaced.
Yes, I have the same impression, yes.
Yes. So I go back to the diffusion because it's very tricky. And sometimes we need to remember that even benign lesions as these FNH, together with the metastasis, they may show restricted diffusion. So restricted diffusion essentially is not a sign of malignancy necessarily. It's a sign of hypercellularity. So we have to remember benign lesions may show impeded diffusion, and malignant lesions such as cystic or mucinous metastasis from colorectal cancer may have bright appearance on ADC map. So benign lesions may have impeded diffusion and malignant lesions may have free diffusion. But actually, as said, diffusion is a sign of cellularity. It's not necessarily a sign of malignancy. And another case, but of course we have to remember the enhancement pattern is completely different from hemangioma. And we have the primary that is a mucinous colorectal cancer. And again, for patients with ADC, you see very beautifully arterial phase hyperenhancement, washout appearance in the portal venous phase, no uptake in hepatobiliary phase, but the ADC may partially be higher than the adjacent liver. So diffusion has to be treated very carefully. It's technically challenging. We have to look always B values and the ADC together. And by definition, impeded diffusion is not malignancy. It's a sign of hypercellularity. Martin, is there any more questions before I go to the next case?
Not yet, not yet.
Not yet. Excellent. Then, if we are done with the first case, and of course, as Fredrik said, the webinar is recorded, so you can still have the time to go back to the images and look in a more calm pace, because I will try to go through all my cases during the live session. So case number 2. This is a very challenging one. So we have a 55-year-old male with a tumor in the pancreatic head, pancreatic cancer, in other words. Staging CT shows unclear hypodense lesions in the liver. So we go for the galloxytic acid enhanced MRI to see, are the lesions metastasis, yes or no? So the reviewer mode will soon be ready. So for all of you that have access to the platform, please feel free to scroll through the images. As said previously, I have the T2 here, the diffusion high B here, the arterial phase, the portal venous phase should be somewhere here, the transitional phase, and the hepatobiliary phase. And to make life easier, I would like you to concentrate on just 2 of the lesions that are on the segment, on the liver segment 7, just not to scroll through the whole image, because it will take some time probably. So let's go back to this one. This is the portal venous phase. This is the portal venous phase, and this is the 3-minute phase. So please take a few seconds, a few minutes to scroll through and emphasize on these 2 lesions here. So late arterial phase, portal venous phase. Probably my portal venous phase has disappeared. I don't see it anymore. Yes, unfortunately, the portal venous phase has disappeared, but we still can do the job with late arterial phase, 3-minute phase, hepatobiliary phase, and the diffusion imaging. I will just change. So take a few seconds. I will also explain the images for those not having the viewer. So we have on 3T, 2 slightly hypertense lesions on the segment 7. This is the late arterial phase. Unfortunately, I still can't find the portal venous phase. It's somewhere gone. But anyhow, we have this one. This is the 3-minute phase. We maybe see some that the lesions become smaller if we compare, let's say, if we compare this one and this one. These 2, probably they are getting a bit smaller. In the hepatobiliary phase, there is no uptake on either of the 2. And this is the diffusion weighted imaging. And as we said, we need to look at the ADC values, the ADC maps, which are unfortunately not here. Yes, I apologize for that. I really apologize for that. I don't see the ADC maps, but let's see. Let's try to make the diagnosis from what we have here. So, Frederick, can we ask the audience?
Absolutely. So the poll is open.
Question. Yes. So what is the most likely diagnosis for these 2? These are images of the same pathology, or lesions. The lesions have the same pathology. Is these hemangiomas? Are these 2 metastases, intrahepatic cholangiocarcinomas, or HCCs? Once again, I apologize for the ADC maps for missing. Probably they disappeared somewhere in the case space of my email when I sent the images. But anyhow, let's say that there were of technical reasons you couldn't get the ADC maps of technical reasons. The MRI technologies for some reason didn't press the button. So we still have the T2s. Here we have the later telophase, a bit of artifacts as we expect them. And the lesions becomes a bit smaller in the 3 minutes phase. No uptake in the hepatobiliary phase.
So we have 60% answering so far. So maybe we'll end the poll here.
Yes, please. Let's see the results.
Here we go.
Okay, this is a derby. So we have 31% saying hemangiomas and 54 saying metastasis. And actually, this is a clear game changer, because if we say that this patient with pancreatic cancer has a liver metastasis, then it's history. He can't get any curative treatment. If we say the patient has hemangiomas, then he or she can be operated upon. So it's very important to try to solve this case out. So let me go back to my presentation. This is case number 2. Okay, this is the Primovist exam that we have been looking at together, and this is the extracellular contrast agent that the patient had a few days later. So what do we see here? This is what we were looking at on the images, the T2, high B, diffusion, and the dynamics. So we saw that the images became progressively a bit smaller during the dynamic phase. Let's go back to the extracellular contrast. This is on 1.5 Tesla, so we see on T2, almost as high as the CSF. And regarding the contrast enhancement pattern, we see that there is a peripheral, nodular, discontinuous, and with centripetal filling, at least in the larger of the two lesions. But I promise these two lesions are the same. And when we look on the T2, of course, we have signal intensity similar to the CSF, maybe not as bright on the 3T because of some technical fine-tuning issues, but on diffusion, we have the B800 and the ADC that I apologize for not showing, having bright signal on both cases compared to the adjacent parenchyma. So what we had here is are two hemangiomas. And I will go through some of the next images on the PowerPoint just to explain how we can address hemangiomas on these patients. We see on the extracellular contrast agent, the hemangioma having typical enhancement pattern, peripheral, discontinuous, nodular enhancement with progressive fill-in and following the blood pool. One hemangioma here and the second hemangioma in this area. Both hemangiomas have high signal intensity on T2 and free diffusion. Okay, extracellular contrast agents. Sometimes we're lucky enough in the hepatobiliary contrast agents to have again discontinuous peripheral nodular enhancement with progressive fill-in. Again, high signal on T2. However, if we are unlucky and we don't have the typical enhancement pattern, as we see in the patient case number 2, we can still use the T2 weighted images, the B800, and the ADC map showing no signs of impeded diffusion. And if we are very careful, try to point that out during the case interaction, you see that there is probably some enhancement, the lesions become less in size. And probably the lesion is not diminishing because of biological phenomena, but is diminishing because there is some enhancement in the periphery. So unfortunately, due to the fact that Primovist is 1/4 of the amount of the extracellular contrast, we don't find all the time this beautiful enhancement in the periphery. But if we are very careful, we can see that the lesions become smaller during the portal venous phase and the 3 or the transitional phase. So this can help us to identify that there is some sort of peripheral enhancement, although not so beautifully as we expect with the extracellular.
Because I have another question. If you have a staging for a pancreatic tumor, what would you prescribe? Would you prescribe a Primovist MR or a non-specific contrast? What do you do in daily practice?
In daily practice, if the tumor is on the pancreatic head, actually Primovist will not give you the additional information, because the patient will have hyperbilirubinemia, so you will not get your hepatobiliary phase. So if the patient is icteric and is not having the biliary stent, so Primovist will not work. If bilirubin is more than, let's say, 3 or 4, the hepatobiliary phase will never come. So it's better to use extracellular contrast agent, because it's cheaper and you will get the same information. However, if the lesion is in the body or the head or the tail, or in the head but after the patient has the endoprothesis, then, at least in my experience, works better. But you need to have the patient.
I missed the part. There was some missing part. What did you say? Can you recall the last sentence?
Yes, I say that if the lesion is obstructing the common bile duct, the patient is...
No, if not, what would you give then?
I would go for the Primovist.
Okay.
I would go for the Primovist because in my practice, we see that the hepatobiliary phase is extremely helpful and some small lesions are not easily seen on either diffusion or the dynamics. Sometimes they are not so easy to see. But of course, this is also a matter of local traditions and expertise, because if you feel unsure about the properties, how to evaluate the properties of a Primovist, then it's better not to use it. It's better to have to use a contrast agent that you feel comfortable with. Okay.
Thank you.
So continuing, I would like just to remind you that if you have a lesion on CT and you want to go through a forward for characterization with MR, if your suspicion is hemangioma, then probably Primovist is not the optimal contrast agent to start with. But if you have already performed your Primovist exam for a patient with colorectal cancer, and you want to see if these are metastases or hemangiomas, you don't need to go necessarily for a next MRI with extracellular agent. You can just try to give it a second chance, look at diffusion, ADC map, T2, and of course the dynamics. And if you see that your lesion is becoming a bit smaller during the dynamics, still high signal on T2, and with non-impeded diffusion, the chances are quite good that the patient has hemangioma and not a metastasis. But it should not be the first contrast agent if your suspicion on CT is hemangioma. Probably it will make things a bit less easy for you. So, any more questions, Martin?
No, not yet.
Excellent. Then we go to the next case, case number 3. Let me close the viewer from this one, and we get case number 3. So we have a 55-year-old male with NASH cirrhosis, surveillance ultrasound with limited views due to patient habitus. So we have the extracellular contrast agent enhanced liver MRI to review in our platform.
I have a question for
yes,
you.
Please.
What should be investigated in case of hemangioma?
Yes, I said, if to begin with, even ultrasound with contrast works pretty well if people know how to use it. Then if you have already done your CT with 2, optimally 3 phases, you can still characterize quite well hemangiomas. If you would decide to go for the MRI, then definitely Primovist is not the best option to start with, because the dynamic patterns and the amount of gadolinium used is much less than the extracellular agents. So it's preferably to go for the extracellular and get the optimal enhancement part in the periphery.
I agree, yes.
But the idea is that if you have already done it, because the patient has colorectal cancer, and you find some lesions that are unclear, is this hemangioma or metastasis, and in particular in patients with pancreatic cancer, this may play a huge role. Give it a chance. Look on T2, look on diffusion and the dynamics. Although you don't get this beautifully peripheral, nodular, discontinuous enhancement, you can still see that the lesion becomes smaller from the periphery towards the center. So this can help you. And I have been using this way of thinking a lot of years now, and in the most cases it works pretty well. I don't know your experience, Martin, on the topic.
Well, this is quite interesting because if we have a pancreatic tumor and we hesitate if it's a metastasis or a hemangioma, we have to be 100% sure if it is a metastasis. Otherwise, patients go to palliation and there are no chances anymore. So we, in a significant number of cases, we do biopsy still to be 100% sure. Okay. If we have high suspicion of metastasis, we still will do a biopsy. I don't know, that's our practice in our hospital.
To be honest, in my practice, our surgeons and our oncologists are very afraid of biopsying things for some reasons. I don't know. I don't know why. So they insist on doing further imaging if we are not sure based on the findings of one modality or one contrast agent, let's say. Is there any more comment or question, or shall I go through the case?
Yeah, you can go to the case, yes.
Okay, excellent. So this patient, as said, cirrhosis, there was some bad limited views on the liver because of habitus. So we have the patient doing the extracellular enhanced MR. Again, T2, diffusion, dynamics on the right-hand side. So I have just to make your life a bit easier, I have some annotations on the images that you need to review. We have it here, all the images that are necessary, and I will try to go through them. So this is the T2. Okay, this is the lesion here. This is the lesion on diffusion. This is the lesion on the late arterial phase. And this is the lesion on the portal venous phase. And since we have the extracellular agent, we have a 5 minutes phase. And the lesion should be somewhere here. So take a few seconds, look at the images. I don't know if Fredrik is ready to show the next question.
Let's do it.
Let's do it.
It's about the sequences, yeah?
Yes. No. It's about, let's go for question 4.
Same as before, yeah.
Yes. So this is the late arterial phase, the portal venous phase. And this is the 5 minutes phase. So what is the most likely diagnosis? The patient has cirrhosis and ultrasound did not show anything because of a limited view. So this is extracellular enhanced MR. So is this hemangioma? Is it metastasis? Is this an intrahepatic cholangiocarcinoma, or is this an HCC? And since I have to be consistent with what I have been telling you, I have to show you even the ADC. So this is the ADC.
Okay, so we got 54% answered so far.
Excellent.
So we'll just end. Yeah, now we got some more. So we'll just end the poll in a few seconds. Okay, here we go.
Yes, please. Okay, very interesting. Very, very interesting.
Yes.
So, yes, was the question?
No, that was my answer also.
Yes.
Very interesting answer. Yes.
Yes. Let's go through the results. We have 33 say hemangioma, 7% say metastasis, 7% intrahepatic cholangio, HCC 53%. This is the majority of the cases. Excellent. Very nice. Let's go to the imaging findings and let me explain what we are seeing here. As we discussed, diffusion, high signal, okay, on B values, and dark map. So this is something that is definitely not hemangioma, because we can, the hemangioma should not be dark in the ADC map, and more importantly, it should not have a rim enhancement. As we see here in the late arterial phase, in order to call this hemangioma, you need to have clear, the definition of the hemangioma has to be clear. It has to be peripheral, discontinuous, nodular with centripetal filling. But in this case, actually we have just a rim enhancement. We have no nodularity. We have no discontinuity. If we look on the portal venous phase, you see almost complete enhancement, but from a part in the center of the lesion, but still no discontinuous enhancement, no nodularity, and it doesn't really follow the blood pool as you see here. And actually, when we go to the 3 minutes phase, I will try to get the 3 minutes phase back on the screen. Get it here. This is a 3 minutes phase. Actually, you don't see any washout. You don't see any washout. You don't see any enhancement like the blood pool. So this is definitely not hemangioma. And actually, this is not an HCC either, because on the HCC, as you remember from the LIRADs, the enhancement should be non-rim. It's a standard criterion that the enhancement should be non-rim arterial phase hyperenhancement. So if I go back to my presentation and share some information with you, this is just a typical case of a very small but still clear intrahepatic cholangiocarcinoma. As we see here, another case, a similar case, the enhancements from the periphery, but it's for sure continuous. It's not discontinuous. It's not nodular. And although it is enhancing towards the center during the later phases of extracellular contrast agent enhanced MRI, we can still see a difference from the classical pattern of a hemangioma that should be discontinuous, nodular, peripheral with centripetal filling. And looking on T2, the hemangioma should be similarly high to the cerebrospinal fluid and not just discretely hyperintense on T2. So hemangiomas may, intrahepatic cholangiocarcinoma may mimic hemangiomas, but if we are lucky enough, sometimes, although we can have very small intrahepatic cholangiocarcinomas like this one, we can still get the targetoid appearance with high signal intensity on diffusion imaging in the periphery and low signal intensity in the periphery in the hepatocellular, in the hepatobiliary phase. And again, ring enhancement with progressive fill-in, but as you see, it's fully rim. There is no nodularity, there is no discontinuity. So this is a typical finding of intrahepatic cholangiocarcinoma. And please remember, targetoid appearance is not always present, but if it is present, it's a highly indicative of intrahepatic cholangiocarcinoma. We see it here. Are there any questions, Martin?
Not yet.
Good. Then we are lucky enough to reach the case number 5. And as you see, I skipped case 4 And it's not due to the fact that I'm superstitious, but when I was just loading up the cases, I made a change in the order. So change 4 just disappeared. So it's not because of a superstition. It's as are the flights in the seats on the flight. So let's go to the case number 5, the last one. So we have a 66-year female with HBV cirrhosis, esophageal varices. Surveillance ultrasound have shown several up to 1.5 centimeter unclear focal liver lesions. It should be unclear here, not unclear. My apologies for that. So ultrasound several up to 1.5 centimeter lesions. So let's see the images. We have 10 minutes. We are on time.
Yes.
Very good.
Perfect.
So again, T2, diffusion, dynamics, and hepatobiliary phase. This is with multi-hands. So I have just for your easiness, I have 3 lesions that I would like you to concentrate on. And I will go through the lesions with you. This one disappeared, but we have it somewhere here, I think. So we have one lesion here. Okay, we see it very beautifully. This is the late arterial phase. This is the portal venous phase. This is the 3-minute phase. And this is the hepatobiliary phase. Okay. But this is not the most interesting lesion. I think all of us would say that this is a Liraj 5 with no discussion. Easily it would be HCC without any issue. This is the same lesion on T2. But the most interesting part are the lesions that are here. So if you are on the viewer, just scroll through the images back and forth. And then we have the one last question for you. These are the T2 series. We have the slightly hyperintense, the HCC. The others are probably iso-intense or hypointense on T2. On the late arterial phase, we have, apart from this arterial phase hyperenhancing lesion, hypovascular, first and second one. Again, we have beautifully capsule, slight iso-intensity, and on the 3-minute phase, clear hypo-intensity for the other lesions here. And again, in the hepatobiliary phase, the most important phase for this patient, we have low uptake in the HCC, but we have low uptake even on this and on this lesion. So if I go back to my presentation, again, I show you the same patient. This is the HCC that we have decided. This is an HCC. But we have these 2 lesions. One is 3.5, and the other is 2.2. Hypointense on all phases, low uptake in the hepatobiliary phase, and no signs of impeded diffusion. So, Frederick, let's go to the last question. So the lesions are most likely malignant, meaning high-grade dysplastic nodules or HCCs, or benign, meaning regenerative nodule or low-grade dysplastic nodule. So again, just think of the Liraj categories or the easels, the dual system, is it HCC or not? So Liraj probably would not be, this is for sure not a 5, but if you would guess, are these lesions benign or malignant? So Frederick, what are the results?
Yeah, so we're still getting some answers, but they are very consistent, I would say. So
there's also a question. There's somebody thinking maybe could it also be a rim enhancement with rim washout in this case?
Meaning in the other
hypervascular tumor, I think, the center. Is it why call it an HCC? Is it not cholangiocarcinoma because there's a rim enhancement?
Actually, this is
rim washout.
It's really not peripheral washout. I wouldn't say.
No, the hypervascular tumor.
The hypervascular.
Yes.
No, I think the hypervascular is quite clearly that it's a non-rim enhancement, I think. And
yeah, I agree.
Then there is a capsule at the already
capsula, yes.
portal venous phase and in the late phase. So this has to be an HCC without any doubts if we are talking about this one. So what are the results, Frederick?
Here we go.
Okay, excellent. I like this number a lot. However, this is something that we need to discuss. So the majority, 92%, say benign. And actually, if you follow the guidelines, you end up with thinking that these are benign lesions because these do not fulfill the criteria of HCC, the imaging hallmarks of HCC, as they easily used to call it. But let's see. I will take you through the images. So this is the lesion. We decided it's an HCC, and this is the late venous phase from CT. So the patient goes through a TACE. Okay, so this is the evaluation of the TACE after treatment. But if you look on the anterior side, this lesion that was hypovascular turned out to be hypervascular and with vascular washout, with very nice washout. So by definition, this is arterial phase hyperenhancement, non-rim hyperenhancement with washout. So this is an HCC2. So we treated this one again. This is the post-TACE number 2. And you see the other hypovascular lesion became hypervascular itself. So we treated this one too. So after the TACE number 3, we have 1 treated, 2nd treated, and 3rd treated. So actually, these lesions are most likely malignant, although the guidelines say that we have to be careful and not assign possibly malignant lesions to definitely malignant lesions. We have to remember that the hepatobiliary phase, both after Primovyst and after Multihans, may be very, very helpful, and it can show us in very early phases high-grade dysplastic nodules or already progressed HCCs. And this actually was nicely seen in a multi-center study in Korea a few years ago, that all these nodules that are dark on the hepatobiliary phase without any arterial phase hyperenhancement, like these two, so these are dark on the hepatobiliary phase with no arterial phase hyperenhancement, the vast majority is already advanced, already HCC, 64%, and 28 are high-grade dysplastic nodules. So of these nodules, only 8% are low-grade dysplastic nodules. So
according to the LIRADS, you would call it a LIRADS 4?
Yes.
And a LIRADS 4 has how many percentage chance of being in an HCC? It's about 70. So
70,
it's still working, no?
70, yeah. But you can't take a decision that this is an HCC.
No,
however,
no, of course, but with this publication neither.
Yes, the reason I show the case is that although we are not 100%, the likelihood is much higher than 70%. It's almost more than 90%. So we have at least to keep an eye on these nodules, the hypointense nodules in the hepatobiliary phase. We have to keep an eye and maybe go for a earlier control or maybe go for a biopsy, because this will turn sooner or later to hypervascular lesions. And it was shown that when these lesions are larger than 1 centimeter or have high signal intensity on diffusion or T2, these two, I mean, the likelihood is higher that they will turn hypervascular in the near future, or if the patient was treated previously for an HCC.
So you would treat them, Nikos?
In my institution, we would be a bit more careful, but this is I think it's a paradigm shift. If I'm not completely wrong, I think that in next versions of the LIRADs, at least I have heard some discussions of people working with LIRADs, that the hepatobiliary phase will probably get a bit more dignity in the future for instead of ancillary finding, there might be sometime a place a bit higher up. But this is, of course, nothing I say officially. It's something that I have heard that there might be discussion in the future, getting the hypointensity in the hepatobiliary phase a bit more important,
Yes.
highly important in the future.
I would personally, in this case, I would, if it would be small, I would give it a chance and do a control in 3 months. But with these large lesions, I would treat in this case, as you shown here.
Actually, we were lucky enough, and they showed to be hypervascular during the controls for the previously treated ones. So we had the chance to treat them too. But if there was a question,
you may not
about,
wait too long. Yes. Mm-hmm.
If it's a question about shall we go for a transplantation, we think it is just one nodule, but the patient has in practical terms 8 HCCs, or shall we wait until we find that these HCCs exist? It's always a difficult question to get the decision and the answer.
Yes, of course.
But since we are exactly on time, I would like to close with the take-home messages, because we have been discussing a lot, and probably our audience, the audience is a bit tired. So for the take-home messages, diffusion-weighted imaging is technically challenging and diagnostically challenging. Sometimes benign lesions may show impeded diffusion, and malignant lesions may show free diffusion. And remember, impeded diffusion is a sign of hypercellularity and not necessarily of malignancy. Hemangiomas are challenging both for differentiating from metastasis and intrahepatic cholangio, particularly the thrombosed hemangiomas or the hyalinized hemangiomas may pose difficulties, but in the majority of cases, they still have free diffusion and high signal on D2. The contrast enhancement pattern may be challenging when you use Primovist, but still you can see some enhancement in the periphery, and the lesions usually get smaller during the later phases of the imaging. And finally, for the patients with HCC, the hepatobiliary phase hypointense nodules without arterial phase hyperenhancement are some nodules that we need to keep an eye on, because these may likely turn to HCCs in the near future. And if there are no questions, because I assume we have to round up, I would like to thank you so much for your attention. If you have anything to ask or comment, please don't hesitate to contact me in my email address, and I hope to see you sometime in the future on site somewhere.
Thank you so much, Nikolaos. It was great. And Martin, thank you so much for moderating. And I mean, we always put a lot of effort into this webinar, so we hope you appreciate it. We will send out, just when we close, you will get an email with an evaluation. So we'd be very grateful if you could fill that out. It will just take a minute. And then if you have any questions specific to the cases, you can actually go to the cases on Collective Minds and reply to the cases to post your questions. So feel free to do that. And we hope to see you next time. And the next webinar will actually not be in July. We have decided to make an interactive case-based quiz in July. So more information will come on that. And then in August, we will have a session again specifically on HCC with Dr. Tomir. So with that said, thank you everyone for joining. Nikolaos, as always, lovely lecture. Thank you so much. Martin, see you soon.
Thank you.
And, thank you very much, everyone.
Thanks, everyone. Have a good evening.
Bye-bye.
Okay. Bye-bye.